Hello, I'm Dr. Marla Shapiro, and I sit on the Board of Trustees of the International Menopause Society. And today I'm joined by someone who is well known to members of the International Menopause Society and worldwide as an expert in the area that we're talking about, and that's Professor Antonio Cano. Antonio, can you introduce yourself to all of our healthcare practitioners who are with us today?
Well, it's a pleasure to be here. Many thanks, Marla. My name, as you said, is Antonio Cano. I am Professor of Obstetrics and Gynecology at the University of Valencia in Spain, and I have been the President of the European Menopause and Andropause Society between 2019 and 2021. And now I am co-chair of the Council of Affiliated Menopause Societies at the International Menopause Society. It's a pleasure to be here with you.
Well, today we're going to focus on metabolic syndrome because it certainly does affect menopausal women and perimenopausal women, and often it isn't the focus of what we may be thinking about when we see these women. So first, let's establish the prevalence of metabolic syndrome.
Well, it is something that changes from one area to the other of the globe, because it is very much influenced by socioeconomical variables and ethnic background and so on. But it is something which is increasing because there is such an epidemic of obesity, which is well established in every country in the world, not only in the most developed countries. And it has been calculated that it may change the prevalence between 20 and 60%, depending on the rates of obesity that that country in particular may have.
So we know what the definition of metabolic syndrome is within the healthcare practitioner community and menopause. Is there an association between the two of them together? Does one exacerbate the other? Does one interplay with the other?
Yes, both things. Yes, both. Menopause is associated with the decrease in circulating levels of estrogens. And we have plenty of data, many experimental data, for example, with rodents, showing that when there is no estrogens, or whenever there is a limitation of, for example, knockout mice for estrogen receptor, in which these are animals that do not have estrogen receptors, there is an increase in the amount of fat and also an accumulation of fat at the abdominal obesity and visceral obesity, which is something which induces insulin resistance, which is considered the link between the different components of the metabolic syndrome. So this is something that is reproduced in the case of menopause, and which overlaps what we find in clinical studies, epidemiological studies, for example, the study of women across the nation, the SWAN study in the States, which has shown, following several hundred of women for so many years, that when the menopausal transition starts, there is an accumulation of fat in the abdomen, central obesity, and also an increase in the amount of fat globally, with a decrease in the muscle mass. So those are basic ingredients that are included and which are crucial for the metabolic syndrome.
So when we think about the indication for menopausal hormone therapy in our population, typically we're thinking about the vasomotor instability as driving patients in to seek treatment. But the hormones that we use for menopausal hormone therapy, how do they interplay in the development of metabolic syndrome or treatment of metabolic syndrome? What is the relationship between hormones in general, either our own or the loss of our own or the addition of therapy in terms of metabolic syndrome? A big question for you.
Well, it's a very interesting question, actually, because as I was commenting, estrogens are crucial for the control of fat deposits in the body, but also we know that in the case of menopause, androgens stay quite stable while estrogens decline. So there is an increase in the ratio androgens estrogens, and it has been shown that this, in the case of women, is associated with the accumulation of central fat. This is something, for example, that we are all familiar with the polycystic ovarian syndrome, in which there's an increase in androgens, and that has been associated also with the accumulation of fat at the level of the abdomen. So this is one indication in favor of that. There are others, for example, SHBG also has been implicated, FSH, follicle stimulating hormones, but the data we have for that are only experimental. Estrogen
Okay.
and androgens are the basis for that.
What about insulin resistance and hormones? How does that play into this?
Well, this is crucial because it has been considered that insulin resistance is the link which put together all the components of the metabolic syndrome, the dysglycemia, but also the hyperlipidemia and hypertension. Insulin resistance is something which is induced by visceral obesity, and as a consequence, there are all the other manifestations of metabolic syndrome. So it is an important determinant, which is induced by the accumulation of fat that we have already commented.
So let's move away from pharmacological intervention and talk about what we can prescribe to our patients in terms of lifestyle. First, address exercise, and then let's move on to nutrition.
Yes, both are determinants in the control of basically weight, and as a secondary effect, also the control of glycemia and lipids and blood pressure. So there is actually a recent consensus of different societies showing that exercise together with nutrition both support each other and can control up to 50% the incidence of metabolic syndrome, which is a lot. So there are very good news concerning something which is easy to practice. Just recommend the 150 minutes per week, for example, of basic physical activity will be enough to achieve those effects. So important physical activity, and as I was commenting, also nutrition. In the case of nutrition, it's quite easy because you just may follow general rules, like, for example, the Mediterranean diet, which is very effective in controlling metabolic syndrome. Only by itself, but much more in conjunction with physical activity.
So I won't let you go until we talk about what's on the leading edge and on everybody's mind. We keep now looking at things like the microbiome and the microbiota in the gut, and whether or not that has an impact in metabolic syndrome. And if it does, is there a role for probiotics? So first, let's talk about the microbiome and how that influences this.
Well, that's a very interesting question. Yes, and there is now some data showing that one new concept, which is dysbiosis, is the alteration in the composition of the microbiota, is associated with low-level inflammation. And this is something which occurs whenever there is an increase in fat. Fat, and the accumulation of fat is associated with changes in the immunity, both the natural and the adaptive immunity, and that all associates with the alterations in the microbiota. There are data from experimental studies, again, showing that, for example, in rodents which have been ovariectomized, there are changes in the gut microbiota, and that it translates even in some signs of menopause, like, for example, the atrophy at the level of the vagina, for example. So this is very interesting, and it's an area which is being investigated and which offers a new window of hope for nutrition, for example, and also for the possibility of using probiotics. But this is something that still needs to be defined, because obviously these are only very initial data that probably will have an implication, clinical implication in future.
Certainly, our patients can look at their diet in terms of prebiotics and probiotics through natural sources in terms of their nutrition, which is one more additional focus perhaps that we can look at.
It is, yes, this is the case. Yes, certainly the equilibrium at the level of the microbiota with neutral probiotics and prebiotics is something that, depending on what we already know, and because we already know that, certainly will help in the control in that metabolism that is altered as a consequence of what we have commented.
Well, thank you so much for joining us today and bringing us right up to date.
Many thanks, Dr. Shapiro. Many thanks, Marla.
Bye for now.